And with that, I'm going to turn it over to Michele. I'm just going to have, Michele, you got to really rate, because this is much better than the table and the folding chairs.
Very nice chairs, thank you.
Michele Tartaglia.
Thanks, Steve. We also hope it's a really good program and hope you guys get a lot out of it. So, like Steve said, I'm Michele. Though I am currently the Assistant Dean of Clinical Ed at Rowan, for the 5 years before this, I was at Christiana Care with these two amazing individuals who taught me a great deal, and the reason they're here and I'm here today. At my orientation for Christiana, I met Dr. Anna Filip, and we both literally started on the same day. And I will let these guys introduce themselves, and then through Anna, who reached out to take care of a patient, because I happen to be an OBGYN. And I got to meet Brett. So I will let them introduce themselves. I think that's the most pertinent.
My name's Anna Filip, and I have been working at Christiana for about 6 years now. And as Michele said, yeah, we met on our first day of orientation, sat down serendipitously at the same table together. And then I started seeing patients, and I knew no OBGYNs in the system except for Michele. So I guess I a little forced you happily into this work. And so I have been really grateful for the friendship and the partnership since then. So I am a family physician by training and have been doing gender-affirming care since residency. And I did my residency at Jefferson in Philadelphia, and then I did a fellowship in faculty development in global health at Brown, and then came to Christiana, as I said, about 6 years ago.
Hi, my name is Brett Herb. I am a behavioral health provider, and I have been working with the transgender population for 17 years. So I provide behavioral health care for adolescents and also adults, doing individual therapy, family therapy. And I connected with Anna because when she came, I learned that there was somebody in the system who had worked with folks, trans people, and provided them with hormones. So I tracked her down quickly and said, I have a lot of people to send to you, because I was having to send people from Delaware up to Philadelphia in order to get the hormones. So Anna and I work together now. We have a gender well-being program right now, gender wellness program, where we're expanding and we're having more clinicians, and Anna has her residents that she's training, which is wonderful. So as they go out into the world, more people can do this work. And we're growing the behavioral health department, and we're also looking to do more wraparound services to help people in the community. We're looking at getting a patient navigator, because there's, and Anna will talk about this, a high level of health disparities with this group, because they a lot of times don't seek out medical care because of their concern about the response. So that's who I am, and I'm also very honored to know Michele and the work that she's done with these folks.
Yeah, so now you know how we got to know each other. And it's funny how we all kind of stumble into this care. I think the neatest part of this is that I agree, the family medicine residents at Christiana, a very large program, and the OB residents now, I believe, also rotate with Anna and Brett through the whole gender program. What's great is, yes, we're talking about Christiana Care, which is not necessarily close to here, and I respect that. But the great thing is, there are programs similar to what I was a part of, and they are growing rapidly, that are happening here in New Jersey as well. I know South Jersey the best. So bear with me. I know that Cooper has an excellent program. There's an LGBTQ+ office within Jefferson Health. And as I understand, Virtua is about to open a nice big center as well. So there are resources here in South Jersey very similar to what we're going to talk about. And I know there's even more in North Jersey. And we'll get to that a little bit later. All right, so we have just a couple slides to get through some of the very basics, but we want this to be a conversation, thus the really comfortable chairs. Thanks again, Steve. I mean, really, this is lovely. But we have a couple of questions that we have pulled from, before this talk, but we hope that you guys come up and ask us literally anything. The only part I will cut off is you hear that none of us perform or are deeply involved in the surgeries for trans individuals, okay? So we don't always have the best answers to those questions. If there's ever a part 2 to this, we were talking with Tima about it, perhaps that'll be a part 2. So this is about primary care, thinking about your offices, and the fundamentals. So with that, I'll leave the slides.
Sure. So to sort of set the stage or get us all on the same page, we're going to do a quick exercise. So if you prefer, close your eyes, clear your mind. If you don't prefer, keep your eyes open, close your mind. Close your eyes,
Definitely
open
close
your
your
mind. Open your eyes, open your mind. How about that? Okay. I'm glad you all were listening. So I am going to describe a person, and I want you to picture that person in your mind. All right? This person is dressed for the best night of their life. They are in their tights, in their dress. The fabric of the dress is a beautiful velvet, certainly has some sparkle to it. They've got their heels on, a little bit of a jewel on the shoe. Their makeup is done, their hair is done, and they have found every jewel they own and are just wearing it beautifully. So, everybody have that wonderful picture in your heads. And I would argue that all of you have pictured King Henry VIII, right? So, my guess is no. And this is just a demonstration that your sense, or our sense of gender identity is really rooted in cultural context. So I would argue that King Henry VIII, for his time, was the epitome of masculinity, okay? And I would argue probably most of you did not have a picture of masculinity in your minds, based on the culture that we all live in now, okay? So just to hit this home, if you know who this person is, please hold it to yourself. And this person is someone who grows up to be a prominent figure in our culture, though our culture of a few decades ago. But this is them in what we would term their Sunday best, sitting for their childhood portrait. I don't know if you know who grows up to be, but grows up to be FDR. So again, congratulations, bonus points to wherever you're from. So I think this is bringing it closer to us culturally, that even just recently we had some differences in gender identity through our own culture, okay? So when I talk to my residents, and I forgot to mention, I am an associate program director of the family medicine residency at Christiana as well. So I do a lot of teaching, and because this is the work that I enjoy, the residents are taught this a lot. I also firmly believe that affirming care is primary care. And so I think that every primary care provider should be providing this care. So when I talk to my learners about it and when I talk to my patients about it, I often use this infographic. So this is what we call the gender unicorn. Some people may have seen the ginger or the genderbread person or other iterations of this. This is by far the one that's most accepted in the community, mainly because it was created by the community. So I talk about this in 3 different ways. So if we start in the middle of the infograph, this is what we call sex assigned at birth. And in this room, we all know that that is more than just male or female, okay? But it's done when someone catches the baby and looks and says, oh, hey, it's a boy, it's a girl, it's a healthy, right? Hopefully is what they say. But we know that it is male-female intersex. So that's sex assigned at birth. Then when we talk about sexual identity, we need to remember that sexual identity and romantic attraction happens in a couple of different ways. So again, take a moment, briefly think about your own current or past relationship history, and think about, there are certainly people in that history who you have been physically attracted to, but not emotionally attracted to. And people you've been emotionally attracted to, but probably not physically attracted to. I hope you have found someone, or will find someone in your life if you want to, who you are both physically and emotionally attracted to and can have a deep connection with. But remember, sexual identity is more than physical or emotional, it's both, okay? And sometimes we need to talk to our patients about it. And remember, some of our patients may be, as we call, asexual, or not have attraction to others. So then when we talk about gender, that is something that is individual to each person, and that is how they feel about themselves, okay? So if you feel that your gender is aligned with the sex assigned at birth, then you are considered cisgender. If that gender identity differs from sex assigned at birth, you are considered transgender, okay? There is some gray area in there as well. Some people may not identify as cis or trans and may identify as something called non-binary, okay? There are also many, many other labels to this, so it's most important to ask each individual their own identity. And that identity can change over time. So it's important that we continue to ask these questions. So you may have your own gender identity, which is how you perceive and identify as yourself. There is also your gender expression. So how do you express that gender identity, or do you express that gender identity to the world around you? That may happen in alignment. So if you identify as more feminine, you may express femininity. It may not align, and that can happen for safety reasons as well, okay, that we'll talk about in a little bit. So that's setting the stage. A little bit of more information about why it's important that we're talking about this is that in 2015, there was the second national survey of transgender health. So there were, in this second survey, over 25,000 respondents to this survey. And just so you know, when we talk about gender identity, on this survey there were 25 gender identities listed, and still 24% of respondents checked the box of other, I don't identify with one of these gender identities. It is a very personal thing, okay? So, in the room full of healthcare providers and physicians, this is one of the most powerful slides to me and why I do this work. So in that survey, 25% of respondents experienced a problem with accessing healthcare through their insurance related to their gender identity in the year prior to the survey. Then you go on, and it's at least a third or more than a third did not access care because of fear of persecution or not getting good care because of their gender identity, whether or not they disclosed that gender identity, okay? And then the second one, or I'm sorry, the third dot, second half of the third dot, really hits on the socioeconomic status and health disparities that we're going to talk about in just a minute. And that is 33% did not see a doctor when they needed to because they could not afford it, even if they had health insurance. And then as a family provider, my concern is the 31% of patients who did not disclose their gender identity to their providers. So for me, that means that we are not providing appropriate primary care and appropriate health screenings to that particular patient. All right, so for me and Brett, and I would argue Michelle too, this is the reason that I do this work. This slide and these responses and percentages of these responses are personally unacceptable to me. So this is what gets me out of bed. This is what makes me do this work. 40% of respondents to this survey had attempted suicide at some point in their life. 50% had thought about it in the year prior to responding to the survey. And over 70% of the respondents who had attempted suicide had done so more than once. So for me, this is where the work needs to be done. Okay.
Just one comment about this slide is that I think it's important to know that the 40% of people that have attempted suicide included folks that were receiving gender-affirming care and also individuals that weren't. So it just points to, even though people are receiving care to help them with their gender identity, that it still can be very difficult, and a lot of that can be because of how they're treated in society, difficulty with getting housing, difficulty with finding work. And so it just points to that this is an ongoing support that folks need as they're living their lives as in their true selves.
Absolutely. So with that, we wanted to start with some questions, and if you have questions, please come up to a microphone and let us know. I want to set some ground rules that this is a very safe place. These questions won't leave this room, so please Ask them however you ask. We may rephrase your question in a slightly more thoughtful way, but only learning happens here. So, any questions? And we can start with very basic ones too. Sure. Sure. Did everybody in the back hear that question? Okay. So if I know it's a lot, but can we get our steps in and go to the microphones and so that we can record the question? So the question was about body dysmorphia and how if a patient is presenting to you having severe dysmorphia, what are some of the tools and things that you can do to help with that? Is that appropriate? Okay. So for me, it's asking those questions. So a little bit of open-ended, tell me a little bit more about that. Tell me a little bit of the specifics. What is it that is causing what I like to use the term dysphoria for them? Is it a single particular part of their body, or is it a general overall look? And when I am counseling patients prior to starting affirming hormone therapy, I ask them in a way of positivity what their goals are for hormones. And sometimes I will phrase that as, in 5 years' time, what do you hope to see in the mirror? And that way, it helps me allow them space to think about their future and to think about their body in a positive way. And oftentimes, that will start with, if this is a trans feminine patient, it will start with, I want boobs, or I want a butt, or things like that. And then I can talk to them about their physique now and say, what I may be able to do for them with hormone therapy. And I think it's really appropriate to set expectations and realistic expectations for the effects that we can have with hormone therapy, because that can really help with that dysphoria that they're having. And oftentimes I'll root those questions in. You say you want boobs. Tell me a little bit about the cis women in your family. How large are their breasts? And so if a patient says, I want, and describe double D size breasts, and I ask, what do the cis women in your family have? And they say, A cup or B cup or nothing. We're gonna have a long talk about how much I can get them with hormones, which is not a lot, but then I have colleagues and friends who can give them extra through surgery. So just setting that stage ahead of time is important. So I imagine you probably get a lot of this too. I'm sorry.
Oh.
Yeah, so I'd like to respond to that as well. The term that you used was body dysmorphia, which is actually different from gender dysphoria. Body dysmorphia, it's a psychological term, and that is about a person who sees their body as different than what it is. Like they might see their arm as excessively long, for example. When gender dysphoria is they're seeing their body correctly. Like, for example, they're seeing that they have a masculine jaw, or they're seeing the genitals that they have. So that's a lot of times people will use that term dysmorphia when it's really just when it's dysphoria, and that's very common. So just to say that, when I'm meeting with folks, I do an evaluation, so I'm there for behavioral health, and the folks that come to me are people who are looking to explore their gender identity, or they may be coming in because they know that they're clear on their gender identity. Whether that's non-binary or it's male or it's female. And so they're coming in the door, so they might have that awareness, but they know that they want to transition, so they want support around that transition. We talk about, well, what is it that you're looking for? So one of the things that they may be looking for, most people do look at hormone therapy, first, and then that's when I would pull, Dr. Filip in. And then the other just important piece for me to say is that I think that this care is best done by a primary care physician. Endocrinologists also do, gender-affirming hormones. But with the primary care, I think then and this is how I explain it to my clients, or I call my clients instead of patients, that they're looking at the whole person. So as Dr. Filip is working with a person with whatever issue they may be having that's disconnected, she's thinking about the hormones that they're on at the same time. So for me, when I'm working with somebody and I ask them, and I do the same question, like what parts of your body is uncomfortable, and they talk about them, we also talk about how to manage that. Like, for example, there are different things that folks can do. For example, like a transmasculine person. So a transmasculine person would be a person who was a sex assigned at birth as female, but they regard themselves as on the masculine spectrum. They may be uncomfortable with their chest, for example. You may have heard some folks wanting chest masculinization surgery or top surgery. So they're struggling with the size of their chest that they have, and so we talk about safe ways for them to manage dealing with the chest that they still have prior to surgery. So something that folks might have heard is that there's some trans masc people who wear binders. These are things you can get on the internet, and it helps flatten their chest. So I share with them different sites that they could go to, talk about safety in terms of wearing the binder and how long you should wear the binder. And so I talk with them about the different pieces, and my role is to talk about, how do we reduce the dysphoria and the things that you can do.
And my role is to know that they might be doing those things and know what medical questions I need to ask related. So are they having rashes under their binders? What are they using as their binder? Thankfully, there are, as you said, some reputable binder companies out there now that provide high quality, safe binders to wear. Previously when I started this work, duct tape and saran wrap was not uncommon, and that is not okay. So I've seen significantly less medical issues around binding than since the binders have come out. So I think the other point in this is to ensure that you are referring to body parts in the same language that your patient is using them. So I will often ask, what do you call your genitals? And some of my patients will have a wide range of answers for that question. I was a middle school teacher before I went to medical school, and the answers are very similar in that. So it's important to mirror the language. Some of my patients will say, it is the thing that will not be named. And so I say, well, I need to talk about that thing that we will not name. And we talk about it in a medical way without naming it as well, okay? So I think that's important.
And just to make another, comment is that, not all trans folks have an interest in transitioning in any way. They're comfortable with living, as their authentic selves without going on gender-affirming hormones or without getting surgeries. And there's always this assumption that everybody wants, the surgery. One of the things that I also hear from clients or patients is going into doctor's offices, and they're going in for a broken arm, and the doctor knows that they're trans, and they ask them, oh, have you had the surgery? Well, they're there for a broken arm, right? So would you be asking a cis person what their penis looks like? Probably not, And so in the same way, you focus on the broken arm. I don't know if you want to comment on that or no.
Yeah.
Absolutely. It's also a shorter visit if you ask them just about the broken arm.
But there's curiosity, so you always have to think in terms of, is this my own curiosity or is it important to the work that I'm doing and being able to treat the patient?
Yes, ma'am.
Question, what age would you initiate hormone therapy for someone who's trying to transition?
So that's a great question. There are a lot of standards of care out there for the appropriate age to do all those things, and that is a probably 3-hour talk in and of itself. But I think the overall worldwide standard of care is WPATH, so the World Professional Association of Transgender Health. They are the number one entity of care. The great news is that they have just updated standards of care 8, should be released spring of 2022, 2021. I realize we're now spring of 2022, but hopefully any day now that new standard of care will come out. For more practical guidelines, the Fenway Institute has some free guidelines online, as well as UCSF. So those are some great resources to start with if you're just starting. When we talk about ages of starting hormone therapy, so there are, for younger people, we need to discuss something called hormone blockers. So that would be pre-pubertal starting of blocking puberty so that a patient may not transition into their undesired hormones, if that makes sense, okay? So if that usually starts around Tanner stage 2, is when we start the hormone blockers. And I personally work really close with my pediatric endocrinology friends just down the road from Christiana to do that work because there is a lot of extra support and services that are needed around that I just don't have the capability of doing at our current program. Then as for an age of starting testosterone or estrogen for a patient who wants to use those hormones, that I will, depending again on their Tanner staging, their age, if they've had hormone blockers or not having hormone blockers, I will really start the discussion around 14. And then the answer is any age after that. Okay.
One of the questions that I know some of my colleagues have asked are, the child in this situation comes to the parent, they have a discussion, the parent obviously brings the child in for this conversation. The thing I'm sure you hear a great deal is, they're just a kid. What if they change their mind? And I'm sure it's a question on the minds of many of the people in front of me, how do you address that, and are these reversible?
Great question. So,
thank you.
When I talk to anyone about, at any age, about their gender identity, it's important to think about it in one particular way. Are they consistent, insistent, and persistent about their gender identity? So if they meet those three things, that means that they are insistent, consistent, and persistent about their gender identity. And I would argue if we all think back to our own gender development and gender identity, we will also be insistent, consistent, and persistent about our own gender identity. And so reassuring parents and support systems and loved ones and caregivers that this is this person's truth and their authentic self is really important. I think it's also important to, and Brett, you can probably speak to this as well, is that oftentimes when a patient, it's referred to as coming out. I've heard the term recently as letting in, and I really prefer that terminology, is when a patient lets in their support system and the world to their gender identity. This is something that they have been thinking about and dealing with for most likely years, and it's only immediate to their support system. So it's important to acknowledge that with the person in the room that you are supporting, as well as supporting the person who is new to this identity and understanding of their loved one. But remember, your primary concern is the patient who's in the room. So coming at it from a place of support and affirmation is really important for everyone in the room, for safety reasons and a variety of other things. But that is really how I start addressing it. And remembering that developmentally, this sense of identity starts really around 4 years old. And some people can, at 4, be insistent, consistent, and persistent about their gender identity. And some people, it's not until later on in development, and particularly when hormones start running through the body, that they really have an awakening or a realization or an understanding that something is not happening correctly.
Right.
I was wondering, could you actually speak to, we hear a lot in the news talking about the suppressing of hormones, the irreversible effects. Can you speak to that for children?
Sure. So when we talk about hormone blockers, we do it in a very controlled and well supervised setting, because we do know that if someone is not having sex hormones, testosterone or estrogen, for a long period of time, then we do start to see long-term effects, particularly on bone health. And so it's really important that we're paying attention to that. And that happens especially right around puberty, but also happens later on in life. So if I have a patient who, for example, is a trans masculine patient and who has seen Dr. Tartaglia and has had a hysterectomy and a bilateral oophorectomy, then we need to have them on long-term testosterone for bone health in the future. You need to have, we all know, you need to have sex hormone in the body for long-term bone health. So Dr. Tartaglia has done some great work with my patients counseling on those long-term effects and understanding of keeping one ovary or taking both out, things like that. So it's the irreversibility of some of these effects definitely need to be discussed before starting. And that goes for any secondary sex characteristic that you might get with starting estrogen or testosterone. There are a few that are hard and fast. So, for example, a deepening of the voice with testosterone is irreversible. So, and that happens by thickening and shortening of the vocal cords. And if you stop testosterone, the vocal cords will not thin and lengthen again without surgery. So that's one example. Another example for a more feminine is, breast development with estrogen is pretty irreversible to a certain extent. If you stop the estrogen, you may lose a little bit of that breast tissue, but you will not lose all of it, if that makes sense.
Yeah, and the other comment I wanted to make is this, the talk about we're giving, our children irreversible hormones. Yeah. That's not what we're doing. What we're doing, or not myself, but like pediatric endocrinologists are just, and you can change my language, is just suppressing the hormones that would masculinize them if they don't think they want to be masculinized. As soon as you stop the hormones, the suppression of the hormones, they will then go through the natural puberty. So it's really important that people hear that we are not putting children, meaning, right, on these irreversible hormones. All we're doing is giving the child time and the family time to think about it and to think and see, do they actually want to transition? And as Dr. Filip said, there's for, a lot of people, when I meet with clients, I say, when do you first start thinking about gender identity? They'll say, well, I knew when I was a child something was off. They won't necessarily, know. Many do know. And then it's when they hit puberty that they're like, wow, I'm getting these breasts. This is just, really wrong. And that's when a lot of the, the adolescent folks come out. But with the children who are younger that we're talking about suppressing hormones, one of the things that's also really important that I think therapists and providers do is we make sure that the parents also work with the kids where we say, this is how you're feeling right now. You may feel differently later, and that's okay. So they don't feel boxed in after they say, I feel like a girl.
Yeah, absolutely. It is, the pubertal suppression is a pause on puberty, and it's recommended not to be on really longer than 3 to 5 years. And if you remove that hormone blocker, they will progress through puberty as they would have had you not started those hormone blockers.
Giving appropriate time to,
yeah, absolutely,
to counsel and help the family.
Absolutely.
Excellent.
Yes.
Yes, ma'am.
So how about the access and the availability and obviously the limitations of trying to get some of these kids, adolescents, and so forth in with mental health counseling, before we're kind of taking some of these steps, as well as kind of helping the families adjust to everything?
You're right. Short answer, there's not enough of us doing it. So I'm glad to see all of you in this room, and I hope this helps get some of you in there to help increase that access to care. It's really, there are a lot of now nationwide networks to start support, and there are support at a variety of levels. Support for parents and guardians, support groups for the patient child themselves. Those would be the places that I start, and we have lots of resources for those. And then I think it's really accessing and understanding what is available in your area. And sometimes it is getting to know the patient as well, to understand the urgency of the need for what services are needed most fastest. And then you have the ability to advocate on your patient's behalf for those.
And I'd like to respond to that as well. You had actually asked about, like, I think behavioral health and counseling. One place that you can look is, she had mentioned WPATH, the World Professional Association for Transgender Health. If you go on to wpath.org and you put in your state, you'll be able to see a list of the providers. And what I would suggest, if there isn't anyone near where your patient is, to call the closest one, and they might have information on a close provider.
As we were
Yeah.
prepping for this, we were all on a video call talking about this panel, and we knew resources, something we definitely want to have for you. So I immediately I went to wpath.org, just dropped in New Jersey. I picked a zip code kind of in the center of the state. I took a southern one and a northern one. There are tremendous resources in North Jersey, tremendous. A small handful in South, a small handful. But I think those individuals, not everybody who does this care is on that website, which is what I really want to impress upon you, to wholeheartedly agree with Brett and say, please just call the person nearest you. I think anybody that does this work is more than happy to refer you to anyone they know that does it as well, especially counseling. Yes, ma'am.
Can you comment if there are any differences in cancer screenings in patients who are on gender-affirming hormone replacement therapy but do not undergo surgery?
Absolutely. And I don't know if that you sent the question in earlier for us, but that is note card 8, I believe.
Yes.
So thank you. So yes, there are some differences. So our colleagues in radiology, the American College of Radiologists, has recently put out a wonderful guideline for mammogram screenings for our patients who have breast tissue. So that is really important to discuss. It's recommended by WPATH that you, and the American College of Radiologists, that you start discussing mammogram screening after 5 years of being on estrogen therapy and having breast tissue development. So that is important to do. The article that the radiologists just recently put out does a wonderful, I think there's about 10 or 12 pathways and wonderful infographics that you just walk down your algorithm with your patient. So they've been on estrogen for 5 years, they are this age, they have a family history of this, and it will walk you down for mammogram screening, which is wonderful and fantastic, and I'm very thankful that that has happened. So for other cancer screenings, so one thing I talk to my trans feminine patients about is that there is no gender affirming surgery, or there's no bottom surgery that will remove a prostate. So we need to discuss prostate screening for the duration of their life, no matter how long they've been on estrogen. So that's another thing that I'm upfront about. I talk to my patients always about cancer screenings in a way that, as your primary care provider, it's my job to take care of the parts that you have for as long as you have them and ensure that they're healthy. Okay, and so Pap smears, there is some, we're not 100% sure what the right interval is right now. ACOG versus, I don't know that ACOG has recently set out new guidelines for them. It used to be a Pap every 2 years. They have since stepped that back a little bit, and so now we're on a regular screening of 3 to 5 years based on co-testing and all the things that we know.
There are a lot of barriers to that.
Yes.
For me to quickly, I am here to moderate. My experts are right here, but the two things I can speak to quickly are, when it comes to gender dysphoria, the number one thing I think an OBGYN deals with is a transmasculine individual who still gets his period or has any kind of spotting or bleeding. Tremendous dysphoria associated with that, very easy to help with. After about 6 months on testosterone, Most menses go away. However, the Society for Family Planning actually came out with a great guideline where Nexplanon, I don't mean to tout any specific, the etonogestrel implant, but it actually works synergistically with the testosterone and all the different studies. This is our group that does all of our sort of birth control study within OBGYN. But there are ways to help with that bleeding, and I have a number of patients who have no intention of getting a hysterectomy. The vast majority, more than 50% of pap smears done on transmasculine individuals come back insufficient. So the talk right now within the college is just single HPV screening most appropriate for this population. So that's kind of where I come into the cancer screening, and there is no. By the way, of note, great data on WPATH, I believe, that testosterone, an individual on testosterone for years has no increased risk of uterine cancer, ovarian cancer. It's not an increase in any kind of cancer risk, to be clear.
Yeah.
So I'm supposed to just sit here and help.
Right.
But
yeah,
I want to
exactly.
jump in now and again. It's driving me nuts.
Exactly. And the only other endometrial cancer, there is some discussion, or there used to be discussion, that testosterone of 5 years, you need to have a talk about a hysterectomy. That has thankfully gone away.
We have one person at the mic,
Yes.
and then I'll jump to Dr. Scheinthal.
Two questions. So what is, I guess, expectation of costs for the person who would be endeavoring, whether it be going towards the hormone path, surgery path, or just cost, because no one knows that? And what are other underplayed medical issues? Because bringing up the binder and the rashes, I wouldn't necessarily think of that. What are other things that we as a provider should actually consider in back of our minds, other than hormones, not hormones, surgery, not surgery, because those are very, I guess, superficial topics, and I think that there's more that we just don't talk about until we're actually in the situation.
Sure. So I guess cost, number one is that estrogen tends to be pretty cheap. Insurances most often will cover the pill form of estrogen. So estrogen is most commonly used in 3 forms: pills, patches, and injections. Oftentimes the cheapest is cheapest, and I would argue kind of most reliable from a production standpoint, is pills. There are often some shortages in injections, and so I often start patients on pill forms, and particularly with a coupon from GoodRx, for example, the estrogen is very affordable. The second medication that you would use often for a trans feminine patient would be a testosterone blocker. So something such as spironolactone is a great example of a low-cost, cheap testosterone blocker. Testosterone comes most commonly used in this country as injectables or a topical agent, so gels, foams, things like that. That is, with insurance right now, most commonly first approved topically, secondly improved by injections. Out-of-pocket cost can upfront can be a little expensive if you try to get them a larger 10 milliliter vial of testosterone. But that 10 milliliter vial will often last most of my patients 4 to 5 months, depending on their dosage. So the overall cost of medication can be fairly low. The cost of surgery, however, is, as you would expect, most of them are a complicated surgical procedure that with long-term recovery. The shortest recovery would be hysterectomy or top surgery, which is roughly 6 weeks of really good rest. And so there's the, missing some amount of work during that. There is the any complications of those surgeries. So some insurances will cover those surgeries. Some insurances will not cover those surgeries. We're working towards making them be covered, making some progress, not a ton of progress, but some. And if a patient cannot afford the surgeries, there are a lot of nationwide grants and groups, GoFundMe pages that are made to help support our trans individuals seeking surgery.
The other thing that's happening, which is good news, is that more and more states are requiring all insurance companies, except for self-employed, self-insured companies, to require transgender healthcare. I do not believe the state of New Jersey is one. I don't know if someone else knows, but like Maryland, Delaware, Pennsylvania. And so in that way, I'm not sure about Jersey, but it's probably heading in that direction, that these surgeries and such will be covered. But otherwise, I mean, they're very expensive, especially if you're looking at the transmasculine surgeries.
I believe we have 10 minutes left. So shorter answers, lots of questions. Those are your job and your job. Shorter answers, lots of questions. Yes, sir.
Hi. There's a controversy in this country right now about trans people in sports. There's some people who are trying to disqualify trans men for taking testosterone for their gender-affirming care, and there's some people who are trying to disqualify trans women for having gone through a puberty that involved testosterone. As clinicians, how do we address this issue?
That's a really great and immediately needed question. What I am really reassured about is that I think just 6 weeks ago or so, the American Sports Medicine Society had their national conference, and this was a topic there. And there is a lot of really good research happening here in the US and in the UK in particular around this issue, which is really supportive of inclusivity of our trans patients and our trans athletes in participation of sports with the gender identity that they align with, so not in the sex assigned at birth. And the data that they're coming out with in this the studies that were presented at the AASSM were that they did all the sports-related things, 100-yard dash and weightlifting and things like that. And for our trans feminine patients, the gaps in those times and those sports metrics closed over time on estrogen. So I think that's important to know, is that the data is showing that if you are using your affirming hormones appropriately and as prescribed, you are not at an athletic advantage to your cis counterparts. And actually the data is indicating that for our transmasculine patients, you are not necessarily achieving equality in the elite masculine sports population, if that makes sense. Cool. There's lots of active research in that, and all of it seems to be moving towards support. Aside from the mental health benefits that we are all 100% aware of inclusivity and activity in sports, socially, for your long-term health, for all the other health outcomes. Sorry, shorter answers. I will stop.
Well, an individual with the other question did step out, but I would like to jump back to a question that was asked a moment ago. And it was, what are some of the things we're not thinking about? You just taught us about binders. What else am I missing here, guys? How about you fill those gaps in, right? Okay. Here's one just from, how did I meet these guys? I performed hysterectomies. The last 3 or 4 hysterectomies I did at Christiana, my patients had full beards, And what have I learned from taking care of patients? When a patient walks in to Anna or Brett's office, they are transgender. They know their gender identity. Patient walks into my office, I don't know, because remember the form, 25 different options, a quarter of people checked other, right? So I have learned a great deal about asking a ton of questions. That's number one. What are we missing here? Ask, 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 ask. If you're not sure of somebody's pronouns, if you're not sure how to talk to somebody, if you're not sure what surgery they've had or how it was even done. So stumbling blocks. Number one, I'm an OBGYN, so bear with me. Number one of the hysterectomies I did for these guys, he had it done on a Friday. He was going back to work on Monday because nobody at work knew he was trans. Well, that's a little bit of a problem for me. It was a laparoscopic, uncomplicated case. I knew in about a week he was going to feel pretty good. I also knew his mom was there with him, and I think the patient was about late 20s, and she was on my side with this. So I actually went to one of Anna's counterparts who was covering labor and delivery, who was a family medicine provider, and had her write the note for work. Helping protect our patients' privacy and choices are very, very important please think about these things. 2, I have patients in my office who, trans males who do not want to give up their uterus or ovaries. I have a trans male patient, college student, the one hysterectomy I couldn't get in because I was leaving, who identifies as a gay male. Well, this college kid is acting like a college kid and having a lot of fun at college, shall we say. How do I talk to him about birth control, right? Like, don't you dare get pregnant. I don't want any pills. Don't you dare get pregnant. It went really well, but we talked. The third thing I will tell you is that I have a trans feminine patient who, a part of how that surgery is done is the scrotal sac is used to create the vagina. So the individual has to go for a lot of laser hair therapy prior to the surgery. I got 3 raised eyebrows, and gentlemen, I love this vantage point. As you can imagine, it wasn't the most fun that individual ever had and did not complete all the laser hair removal. So she comes in about every 3 to 6 months to have me deal with the vaginal hair. And so I was like, okay, what do you need me to do for you? Teach me everything. She taught me everything I needed to know. We had a great conversation, and then we immediately got on because I just admitted my ignorance because I did not know that was even coming. I blame you too.
Sorry. Yeah, that's really my fault. I really apologize.
But you know, that's it. So these are some of the things I've stumbled across, some of the stumbling blocks I've hit, and hopefully they help. Yes, sir.
Quick question. When you were talking about the statistics that about 30% of trans folks felt like they had a negative experience with the medical community, I'm sure some of those folks never made it to the back office. So could you talk a little bit about what you've done with your practices to kind of make it more accommodating or make it feel safer for those folks that are coming in that might be trans that you don't know?
Yeah, that's a great question, and I think that the two of us have been working really hard at that, and it's really shifting mindsets, but understanding the goal of the entire interaction. So one example is, for me, when I enter a room, the goal is to make sure I'm in the right room and do that as efficiently and as quickly as possible. So in an affirming way, I will enter the room, I knock and I say, "Hi, I'm Dr. Philip, what name do you prefer?" And so that gives me it's just as fast as saying, "Hey, Mrs. Whatever," and then having to put my foot in my mouth because Mrs. is Mr. and it's all messed up now. So if I let them tell me who they are, I have the ability to verify where I am. But I agree, that is once they're into my room. So that starts at the front desk. How may I help you? And really training people to ask those questions in an open way. So how may I help you? Question mark, end the sentence, end the question. Try not to add the sir, ma'am, whatever into that, because that may be misgendering your patient. So asking that in an open-ended way. Unfortunately, we still have these barriers of insurance companies and the need to have names and identifiers match and things like that. And so if they say a name that is not on the schedule at all, there are tolerated labels for those kinds of names, often called legal names or administrative sex. Is the sex assigned at birth and assigned to the insurance company at our institution? What is an administrative sex? I don't know, but so legal name you can ask as well, which is an accepted term often in the community and an understanding of that, which I think fits our same Christophers who prefer Topher or Chris and Alexandras who prefer Alex. So I think it really is an entirely inclusive way. So I really start with language. And then we try for environmental cues, advertisements and posters showing inclusivity, and
The intake form.
the intake forms, yes, absolutely. You know, a line for gender as opposed to a box. although EMRs love boxes and clicks, so it's really hard to get around. We've been working for 5 years now to have gender identity in the banner bar, as well as preferred and affirming name in the gender bar, in the banner bar. So just for example of a term you may hear in the community, a patient may come in and if they are upset, they may say, I was dead named by your staff or your front desk or X person. Dead naming is when someone uses their non-affirming or non-preferred name, okay, without the patient's consent.
Just to add on to that, when she talked about the administrative sex being the sex assigned at birth, it's not always that, because some people have their sex changed with their insurance company. So for at least our EMR or EHR, the sex is the one that's connected to the insurance company. So that's always the question we need to ask is what is, and when patients call and they may change their name with their insurance company, if they want to leave the gender marker as male or they want to change it to female, then they need to tell them that. Sometimes they just immediately change it. So it's really tough, but there's also ways working around your EHR in terms of we have like a reminder section where we have, name used, pronouns used that the front desk should see when they come in. One other question people often ask is, what do I do if I use the wrong name or I use the wrong pronoun? It's just a simple apology and move on. I mean, trans people expect that people are going to make mistakes. It's absolutely fine. But to not say, you don't feel that you need to say, I'm really sorry, I really do support you. But just to simply say, you know what, I'm sorry I made the mistake, John.
Thank you.
Yeah. I did it over lunch. I had a small office, and we just had a session like this over lunch one day. And just ask anything you want. Patients are going to start coming. Ask me everything you've ever wanted to know. It was a small office, and it was a really cool conversation. What we didn't know, we all looked up. It was actually really interesting. But I think just sitting in the lunchroom and having lunch together and having a conversation about inclusivity went a very, very long way, along with all the other things they had said. Anybody have any other question? Oh, one more.
Hi. This is my question is, how large is the benefit of appropriate gender-affirming therapies in reducing major depressive episodes and suicide attempts? When I see the very alarming rates of suicide, are these individuals who are getting appropriate care or not?
So we know that that U.S. Trans Health Survey, if you drill down the data, it was a combination of some who had been getting care and some who had not been getting care. And that 40% statistic was at any point in their life. Correct. It is worse if they are not getting affirming care. We are showing some improvement if we are providing comprehensive affirming care. Absolutely.
There's many studies that show like a reduction of gender dysphoria, discomfort with body if they're having surgeries, many in terms of, using different scales to assess for, reduction in depression, reduction in anxiety. And that's one other important point is that when someone has gender dysphoria, the distress can often cause, anxiety and depression. So as soon as they start getting the care, they don't have that. But then, of course, they're just like anybody else, or they may struggle with a major depressive disorder that has nothing to do with their gender. But there's lots of literature on the questions you're asking.
And both reduction in those things, but also improvement in quality of life. So the positive to that is showed.
People talk about gender euphoria, and that's what changes for them.
Euphoria instead of dysphoria. Yeah,
right.
absolutely.
That's a perfect way to end.
Yeah.
Literally on a high note. I know we're coming obviously to the end of our time. I want to thank you guys. We had so many prepared questions just in case, but this session was for you, and so I'm glad you got to ask your questions. If you have any more, we will be here for a little bit longer and happy to answer whatever you need. Thank you for your time.